Welcome back to Therapeutics. In this block, we're going to review a number of issues related to dermatology. And in therapeutics, there are a few things that we do in derm. Usually, our intent is to reduce the inflammation and or symptoms of a dermatologic condition, make the patient more comfortable. When we talk about infectious disease-related conditions, we'll talk a bit about the modalities we have that will reduce infection risk as well. And we'll also talk a bit about the non-infectious diseases affecting dermatology. In some of the non-infectious diseases affecting derm, we'll see some of the same agents we see again in other conditions of severe inflammation or autoimmune type conditions where we use immunomodulators. Those other conditions include rheumatic conditions, so you'll see some of the same drugs used there that are used in serious, for example, psoriasis. And we'll see some of the similar agents as well used in GI for Crohn's or ulcerative colitis. And then we'll talk about a few other therapies and finally wrap up with treating or managing issues related to lice and scabies, that kind of thing. So as we get started with derm, one of the things to recognize is that when we use or apply a dermatologic intervention or treatment topically, those different formulations actually, or the vehicle that the drug is in, if we're actually giving an active ingredient in a topical therapy, the formulation that ingredient is in makes a difference. And sometimes we're just looking actually for a protective barrier or something else that the vehicle itself or the formulation itself is enough. So sometimes, for example, an example of this might be a simple wet dressing. And a wet dressing is often it's a dressing that might be soaked in, for example, normal saline or Burrow solution, which is slightly astringent. And they're useful for cooling inflamed or dry oozing lesions or where there's some pruritus associated with a condition. So sometimes just the dressing itself is enough to both offer some symptom management for the patient and perhaps look at cleaning up that area or making it a little bit easier for the body to do its natural response in healing. We also have, related to that, baths, which are similar to wet dressings but a larger area, and these are also effective for urticaria or for weeping or crusting lesions. And examples of these might be a colloidal oatmeal bath or an Epsom salt or mag sulfate bath, or sometimes using a bath oil, which is in a sense of greasiness or occlusiveness. One of the concerns for using, for example, though, a bath oil, an oil in a bathtub, it makes everything very slick. And a concern for that, particularly in older patients, is a risk for a slip and a fall, which then could lead a risk for a fracture. And so many clinicians, while it might make sense to consider using a bath oil product for topical application to the skin, or putting a oil in a bath that the oil skims to the top, and then when a patient gets out of the bathtub, the oil sort of slicks on the skin and keeps the moisture in the skin. For the point of view of the skin, that's a great option for dry skin, but the problem is that the environment the patient's in is so slick, the risk for a fall and a slip probably far outweighs the risk for or the benefit of that topical product. And so a lot of clinicians actually don't use bath oils because of the risk for slips and falls. We have a lot of products that are available when we want an active ingredient in that. Let's say, for example, a corticosteroid like hydrocortisone. And we can use a cream formulation or an ointment formulation. Those are the two major formulations we think of. And a cream is effective in that patients generally like creams, in that you can rub them into the skin until they more or less vanish. And they don't leave too greasy a feel on the skin, so patients kind of like that. They don't like the sense that their skin gets greasy feeling, as opposed to ointments, which are more occlusive. An ointment actually will apply to the skin, will create a more consistent barrier, and that does a couple of things. It keeps moisture more likely in the skin while keeping the whatever could cause evaporation of more moisture out, reducing that. And an ointment also drives more of an active ingredient in an ointment into the skin than you'd expect to see with a cream-based product. And so, for example, if we were to use hydrocortisone cream versus hydrocortisone ointment, the differences would be that with the hydrocortisone ointment, you would actually deliver more hydrocortisone to the dermis than you would if you used a cream formulation. The other disadvantage of an ointment, though, is that it creates a barrier, occlusive barrier. So if you have a wet or oozing lesion, that's usually not a good idea because you want that to dry out a bit, and you're giving an occlusive barrier there that is not really helpful in an oozing kind of wound. The other concern with any ointment is that it stains clothing, it stains bed sheets, and so patients often don't like ointments because of that staining nature of staining or ruining clothes or bedding or the like. So the two real derm formulations clinicians are often faced with is, do I put it in a cream or do I give it as an ointment? And again, in summary, creams deliver a little less drug, or it's a little less potent when it's in a cream base versus an ointment base, because the ointment will deliver more drug to the dermis, and also the ointment is more occlusive and is better maybe for very dry skin, but is a problem in staining, and patients usually don't like ointments. Other options include aerosols. Aerosols are helpful when you've got a larger area to cover and or a hairy area. And typically one classic aerosol product that's been on the market for a couple of decades now are aerosolized sunscreens. And so the advantage is that they're easy to apply for patients and they cover an entire area. But you have to worry about aerosolation of aerosolized particles that could be inhaled if that's an issue. You also want to know that technique is appropriate. Usually it's sprayed for about 6 inches above the area where you want to apply it in a 1 to 3 second bursts. And you generally want to avoid aerosols near the face, partly because it delivers perhaps to the eyes, to the mucous membranes, and also the inhalation risk of that product if that's an issue. We also have a few other dermatologic formulations. Powders are used sometimes for areas, abdominal folds, for example, or athlete's foot where there's chafing in the groin area. These include talc, which we generally avoid talc these days. Talc is related to asbestos. Asbestos causes a particular risk for cancers. And so there is concern, for example, and you may have actually seen direct-to-consumer advertising by lawyers. If you have used a talcum powder, if you've used shower to shower or something, and a woman has a uterine cancer or something like that, you may have a lawsuit against the manufacturer of this product. So we generally don't use talcum powder anymore. And in fact, most of the powders that are available have an inert ingredient. And the powder itself could be a little drying, which might be helpful if there's some moisture. But the problems with powders, be they have an active ingredient like an antifungal in them or nothing in them other than just a vehicle of powder, is that while they're a little bit drying in moist areas, they can actually cake up and end up with quite a mess. And so powders have fallen a bit out of favor for a number of reasons. Lotions are still quite popular depending on what the particular product we're looking for and whether or not it has an active ingredient or the lotion is intended just to cause some minor or moderate occlusion to allow for moisturizing skin. And the lotions are a little more liquid, have a lower viscosity, for example, than a cream does, and it can be applied to a larger area. They're not as effective for dry skin. They're better than nothing for dry skin. So we have a lot of hand lotions, for example, that provide some barrier to dry skin. But if it's a very dry, brittle skin, lotions probably won't offer as much benefit as a cream, and cream probably is not as much benefit as an ointment. And there are different active ingredients that might be in a lotion. There are some lotions with a corticosteroid. An example here is a drying lotion, calamine lotion, which is sometimes used for weeping lesions like poison ivy, which is just a mix of zinc oxide and a little bit of iron that gives it the classic color but doesn't really do much. There are also, among other things, gel products. Gels are clear. They're not staining. They're not occlusive at all. They dry quickly. They offer no real barrier, but they're helpful when you want to avoid an oily or a greasy product entirely, and or you have an area where you want to apply it in a small area. They may be helpful also for the face or hairy areas, and there are gel formulations for a number of products. For acne products, gels. There are also products that are available as corticosteroids available in a gel delivery system as well. Now let's talk for a minute about emulsions. And in fact, we've already talked about emulsions. We've talked about emulsions are basically small, tiny particles of oil dispersed in a water base, or small, tiny particles of water or spheres of water immersed in an oil base. And these are the classic examples of creams and to some degree some lotions. And creams and lotions can be either an oil and a water base, which is less greasy because what patients usually feel is more the water base, which is not greasy, or a more greasy, more occlusive emulsion would be a type of cream base that has a water particles immersed in oil, and these are more greasy, more occlusive. And so you'll find, for example, there are some products that are creams, but some have a more occlusive nature than others, and it depends on whether they're oils dispersed in water, which is less greasy, or water dispersed in oil. So the nature of greasiness for different products varies. For example, a product that's been around for decades, Eucerin cream, is a little more greasy because it is typically a water in an oil base. When we think about the vehicles that we're choosing, we also look at what our goal is for the patient. And we alluded to some of these issues as well. Age differences in dermatology. Older patients we allude to have thinner skin, so they absorb more than younger adults. That's also true. Children, because of their surface area and skin thickness as well, are problematic. We also want to look at the areas where skin is absorbed, the drug is absorbed more through the skin, and that's thin areas, particularly in the groin or in areas where there is a thinner barrier to get a drug to get into circulation. So absorption of drugs into systemic circulation, we see that areas where there is a high degree of peripheral vasculature and thin dermis protection. We think here, for example, the scrotal area, the vulva, the anus in adults. We really have to be paying attention to whether or not a drug is going to be systemically absorbed to a high degree in those areas. And so when our goal is to only use the drug and have the drug have an effect topically instead of systemically, our goal would be to either avoid these areas entirely, or when we use a drug there, be aware of the risk for systemic absorption. Now, sometimes that's used to advantage. For example, one site of application or sites of application for transdermal testosterone in men could be areas where the skin is thin. And so that might be the axilla, under the armpits, could be in the scrotal area as well. And those are delivery options that deliver more drugs systemically. And particularly with testosterone, at least some of the formulations of testosterone, you really don't get high levels of bioavailability of that testosterone if given orally, and you do need to give dermally to get a systemic effect. There are other areas where there's going to be reduced absorption. Those are areas where the hands, in the palms of the hand, soles of the feet, where the dermis is particularly thick and you don't have a lot of peripheral vasculature in those areas. And so you're going to have less absorption there. And then most other areas, we worry about some degree of absorption as well. Certainly would worry about facial areas with some absorption, particularly around the oral area or near the eyes, for example, or near the nasal passages as well. We're concerned about giving a drug, as we alluded to damaged skin, particularly burns or inflammatory area where you can have a dramatic increase in the absorption of the drug. And then the well-hydrated, soft, supple skin generally provides overall better absorption of a drug as well, because the integrity of that skin sort of lends itself to, depending on the nature of the drug, the partition coefficient, those things. But the moisture content can have some variation. Again, that in part depends on some of the drugs that we use. So let's talk about probably one of the most common topical agents that we're going to use in dermatology are the topical corticosteroids. And these are anti-inflammatory. We're going to use them in conditions that are associated with a lot of inflammation. These include atopic eczema, allergic contact dermatitis, and other conditions where we see a fair amount of inflammation. The contraindications of corticosteroids are areas where the corticosteroid itself actually makes matters worse. And the classic areas we want to avoid corticosteroids are, first of all, acne. A patient who has acne, we don't want to use a corticosteroid to the acne lesion or the acne areas, because in fact what we'll see is a worsening of their acne. So that's an important consideration. We also want to avoid giving corticosteroids to ulcers or areas of wounds, partly because, keep in mind, that corticosteroids may impair wound healing, and so we generally want to avoid giving it to a wound or area as well. We also want to avoid it when there is any question of infectious disease process of any kind. And usually the issues we think of here classically are scabies, that a patient may have scabies. Well, you need to rule out scabies before you apply the corticosteroid, because a topical corticosteroid can actually make that worse, not better. Warts, a viral infection leading to warts, topical application of corticosteroids to wart can make the wart significantly worse. And the same is true for fungal infections, where you want to avoid corticosteroids for fungal infections as well. So those are really important rule-outs before you give a corticosteroid or prescribe a corticosteroid to a patient topically. Adverse effects of topical corticosteroids are generally well tolerated. You may have a little bit of, depending on if you're using a potent corticosteroid and or to a large area in a vehicle where there's more delivered, you may have atrophy of epidermal or dermal layers. You could have changes in vasculature in that area. You could have fine hair growth. You could have increased bruising, changes in pigmentation, rosacea, or worsening of acne, as we alluded to. The other concern is the suppression of the hypothalamic pituitary adrenal axis. And in those circumstances, we generally don't see most topical corticosteroids actually suppress cortisol levels secreted by the adrenal gland. But if you are using a potent corticosteroid to a large area of the body where there is likely to be some systemic absorption of that corticosteroid, over time, yes, you could have HPA axis suppression. And so as a clinician, we need to really be aware of that. So that's one of the reasons why we're going to avoid corticosteroids to open lesions. We're going to avoid corticosteroid application to the groin area, to areas where we know there's systemic absorption. And we're going to pay attention to how much corticosteroid we use, how potent we use, and what percent of body it's applied to over time, and keep an eye out for the risk for HPA axis suppression. We talk about in other areas of the curriculum about using corticosteroids like prednisone, for example, and sometimes in dermal cases where they're severe, we will give a pulse dose of prednisone, similar to what we do, for example, and we cover in the pulmonary block when we talk about using pulse dose or 5, 7, 10-day corticosteroid dosing for asthma or perhaps COPD exacerbations as well. So we worry about that there when we're giving systemic corticosteroids, but even in topical agents, when they're very potent to large areas of the body and there are factors that increase systemic absorption, we could conceivably worry about that as well. The guidelines for using corticosteroids topically, typically we want to monitor how much we prescribe to a patient, how frequently they're getting refills, and make some assessments for what our long-term goal is, Can we manage this without corticosteroids in the long term? What is the risk for adrenal suppression? And again, that's usually only when it's a large area or potent corticosteroid that we worry about that. But usually we also want to nip this in the bud. So if it's a particularly inflammatory condition, sometimes it's helpful, a rationale to consider a higher potency corticosteroid early on for a short duration than prolonged use of a lower potency corticosteroid topically. And then after control is achieved, we want to maintain it with the lowest potency preparation possible and look at other factors that contribute to that inflammatory state and see what kind of non-drug interventions can be done as well. The guidelines for picking which corticosteroid, there's lots of sort of data out there for looking at that. But typically, if you're looking at an area where the skin is thin, you want to look at the steering toward a lower to medium potency agent and reserving the very high or super potent agents for treating chronic areas where there's a lot of cell turnover, hyperkeratotic, or lynchified types of lesions. For example, severe psoriasis at the elbow or something like that. And you want to consider, whenever we consider corticosteroids, we generally want to avoid corticosteroids on the face entirely. And if you absolutely need to, use a low potency agent for the shortest duration of time. And we want to avoid the more potent corticosteroids. Those are often the fluorinated corticosteroids, particularly in the face and or areas where there's going to be a lot of concern. So in general, we try to avoid corticosteroids on the face entirely. But if it's warranted to consider that, then we're going to use a low potency agent when we can. The opposite of that is on the palms, the soles of the feet. We often require, when you need to use a corticosteroid, you need to use a higher potency agent. And it's uncommon to use a corticosteroid there. And particularly in the feet, you want to be concerned about, does the patient have diabetes? Is it a diabetic foot infection for which corticosteroids can make that certainly not better and perhaps worse? Is there a fungal infection? Is there a plantar's wart? All of those are considered contraindications for using topical corticosteroids. And in older patients or in infants, when we have to use corticosteroids, we usually try to use a lower potency agent because we're worried about systemic absorption. The vehicle we choose also influences things. Ointment-based generally is going to be more effective for thick lynchified types of lesions, and you're going to have a little better penetration and absorption of, or the potency of the agent is going to go up a bit when you use an ointment base versus a cream base. But a cream base is generally more tolerated for many patients. Solutions, gels, or sprays are better for scalp areas or when you need to apply to a larger area. And then you want to consider whether or not occlusion makes sense for you. So occlusion, whether or not you're using an ointment base or you're using an occlusive dressing, a dressing which is not going to allow much airflow to that area. Occlusion may make sense when you don't have an infectious process. It's a very dry lesion, and you want to allow the fluid to really penetrate, or moisture to maintain or stay in that area of application. But in many cases, occlusion is the opposite of what you want. Particularly, you want to be careful about occlusion in an infectious state. Things that we think about in general, we're looking at avoiding the very high potency agent for longer than 2 or 3 weeks, unless the lesion is limited to a very small area of the body. And in those circumstances, still you may decide, hey, this really, we're not getting the kind of results we want. As a practitioner, unless you're working in a derm clinic and that's your practice, more often in primary care, or if you're ordering corticosteroids in a patient, you're doing it. And if you don't see the results you want in a couple of weeks, usually you're probably going to refer that patient to a derm consult anyway. So for medium and high potency agents, you want to look at maybe a 3-month window of time, and then consider whether or not it's intermittent versus continued use. But the other thing said, if you're treating a condition that is not getting in good control in a couple of weeks, it's probably warranted to consider, do I have the right diagnosis? In fact, if it's gotten worse, is it a fungal infection? Is it a viral-based type of situation that the corticosteroids are making it worse? Is it bacterial infected? Again, that's making it worse. So all of those are important. And most of the preparations that we deliver can be delivered either once or twice a day. And a lot of conditions are benefit from a low to medium potency corticosteroid. You want to always, though, keep an eye out if there's anything that's purulent, draining, crusting, anything that looks like it could be infectious. You want to immediately stop the corticosteroid and address that appropriately. So all of these are considerations. So all things being considered, you're considering the nature of the lesion. Is it wet or is it dry? And is there a role for a corticosteroid? And if so, based on the location of the lesion, how large the body surface area is of the lesion, whether or not you want a lower, a medium, a high, or a very high potency corticosteroid, whether you want the vehicle to be an ointment, a cream, or a gel, lotion, aerosol, something like that, foam, depending on the delivery site of application. There's something called the rule of nines. These are what you'd consider a simplified way in an adult or a child to estimate what percent of their body surface area a particular area is. So the head and neck constitute about 9% of body surface area. The anterior trunk about 18%, posterior trunk 18%, arm and hand 9%, the groin to the knee 9%, the knee to the toes another 9%. And then there's another sort of rule of how much corticosteroid you are looking at ordering for, and they usually come in, for example, a cream or ointment typically comes in a 15 gram, a 30 gram, maybe a 60 gram, some in a 120 gram tube. And for a 3-time-a-day application, 9 grams of cream covers about 9% of the skin. So that's as you get into practice and you see the kind of lesions you're seeing, it'll become, and how large the surface area is, you do an estimate, you're able to then, take this sort of rule of nines, and it becomes more intuitive in your practice over time. But you can estimate how much do I prescribe based on what's the body surface area. And again, if it's a larger body surface area, you've got to consider about is there a potential for, depending on the agent I'm using, what the potency and vehicle is there a concern for suppression of the hypothalamic pituitary adrenal axis? There are a number of key points to consider with corticosteroids. Here's an example of something that was published a decade ago or so, but our recommendations for practice that still sort of are considered pretty valid and standard, and they really haven't changed all that much. Topical steroids for treating psoriasis or other types of lesions generally make some sense. That the ultra-high potency steroids are used for not more than 3 weeks, that the low to high potencies for not more than 3 months, and that we generally look at avoiding topical corticosteroids and antifungal products. There are antifungals that mix with corticosteroids, but I have to tell you that dermatologists generally hate these because the corticosteroid makes the fungal issue worse, and the antifungal may not deal with the inflammation process. So you decide or determine if you've got a fungal infection, then if you're pretty sure it's fungal, you give the antifungal and not the corticosteroid because the corticosteroid makes that worse. There are a few other tables that are listed in the next couple of slides that I encourage you to have familiarity with. And when you get into clinical practice, it'll become more clear based on the formulary you've got and which agents you've got about which agents you're going to likely choose. But truth be told, most clinicians don't absolutely have this memorized until they get to a clinical practice. But you want to consider which types of conditions we use where we're going to use a high or very high potency corticosteroid versus some of the conditions where you would look at a medium potency or low potency. And One of the things I want to lead your eye to is in the medium potency category where there is scabies. And the issue with scabies is you will certainly with scabies have itching and pruritus associated with that. But you want to make sure that before you give the corticosteroid that you have appropriately treated the scabies with an anti-scabicide, an agent that is effective at eliminating the scabies before you look at treating the inflammation that the scabies has resulted in. So important to keep that in mind and always think about the contraindications or problems that could be made worse by a topical corticosteroid. Other things that we're thinking of here are some of the common potent topical corticosteroids. And there's a fellow pharmacist who has recently done a presentation that I was able to take advantage of. And as we looked at here, he had a nice simplified table of some common corticosteroids based on potency. And some of these topical corticosteroids are actually very expensive. And so as a clinician, I think it's important for us to recognize that there's a lot of sticker shock that happens with patients. And so what would encourage you and what you'll probably learn quickly in practice is which of the agents, topical corticosteroids, for example, are going to meet the needs which you have for the patient, but do it in a cost-effective way. And so typically what's asterisked on the next few slides are the agents that are generally relatively inexpensive, meaning that they're under $20 for a typical amount, sometimes considerably under $20. But some of these agents can be hundreds of dollars for a tube, and it's really sticker shock when patients get to the pharmacy. So, for example, for the highest potency agent, a driproline ointment or gel, a betamethasone dipropionate, augmented by the vehicle it's in, is a consideration that usually fits the bill for many clinicians. And a high potency agent is Elicon ointment 0.1%. And usually in practice, I'll tell you as a person who practices in the hospital, I usually go by generic names of drugs. But in dermatology topical formulations, there may be the same active ingredient in 3 or 4 different creams or ointments, but the vehicle that it's in or the salt form that it's in affects the partition coefficient or something else. And so even though you're looking at the active ingredient in some of these preparations, sometimes the brand name or the formulation it's in, if it's an ointment or a cream, make a big difference in the potency. And so you want to just be careful about that when you're looking at which agent or topical corticosteroid you're considering using. Slide that looks at some of the medium potency agents. Again, the cheaper agents, the Kenalog or Aristocort cream, 0.1%, or the Elicon cream or lotion, 0.1%, are generally reasonable, cost-effective choices in the medium potency categories. Lots of other agents are listed here as well. And then for the low and very low potency are Kenalog, Aristocort creams and ointments. And finally, over the counter, typically corticosteroid, hydrocortisone creams particularly are considered very low potency, and those are available over the counter and usually under $10. Some of the potential side effects of topical corticosteroids, as we kind of alluded to this, atrophic changes, you can have easy bruising or skin fragility, particularly that's seen over time if you change in vascularization as well. We're always concerned about worsening an infection or actually that the drug topically or the topical corticosteroid itself may lead to contact dermatitis. Certainly delayed wound healing, changes in skin pigmentation is a concern. We're also worried about corticosteroids when they get near the eye. We can see cataract risks go up. You can see increased in glaucoma potential as well. And then when you have systemic absorption of corticosteroids, if you've got that much and start to see corticosteroids systemically absorbed, changes in blood sugar control, particularly in patients with pre-existing diabetes, Cushingoid types conditions as well. And so lots of things to think about as a clinician. This, in a sense, is a review here of topic that was also covered to some degree in is covered usually in endocrine. But I repeat it here because of our concern and sequencing in the curriculum, but also to give you an awareness and a reminder of when we use systemic corticosteroids in dermatology, the things we need to think about. So if we think about quickly in the endocrine system, the hypothalamus releases corticotropic releasing hormone to the pituitary that releases adrenocorticotropic hormone to the adrenal cortex that releases cortisol. And cortisol naturally causes anti-inflammatory properties, affects gluconeogenesis, protein breakdown, also can be associated with some of the mineralocorticoid effects that are caused to salt and water accumulation as well. So the issue here in the we look at adrenal cortex hormones. We think of basically three things going on. We think of cortisol release, which primarily we're going to use to reduce inflammation. We also look at the androgens to some degree, depending on whether or not androgens are released to cause testosterone and estradiol release. And we worry about more of that issue in men's health and women's health. And then the mineralocorticoid effect, the aldosterone effect, causing the accumulation of salt and water, and that's particularly problematic in cardiology and also to some degree in other conditions where we trigger aldosterone secretion to hold on to more salt and water. For example, we think about that in ascites in liver failure patients as well. So the mineralocorticoid effects of corticosteroid and some of the corticosteroids we give exogenously, like cortisol, have some mineralocorticoid effects, which is aldosterone-like effects, which will cause more accumulation of salt and water. So patients could have fluid edema, for example, when we put them on hydrocortisone or prednisone because of these mineralocorticoid effects when we give it systemically. They can also cause an elevation in blood pressure and changes in potassium and hydrogen ion secretion, particularly hyperkalemia could be a potential concern for us if it's excessive aldosterone-like effects. Most of the time when we're using an agent for a corticosteroid systemically particularly, or a topical agent that has a lot of systemic effects, we're seeing a lot of metabolic effects. And some of those might include increased hepatic gluconeogenesis. We see a change in peripheral glucose uptake. We see lipolysis, which changes in fat deposits. And we see also an increase in serum glucose. This is particularly problematic in patients with pre-existing diabetes. You'll also sometimes see central nervous system changes. Sometimes it's a little bit of hypomania, excitability, maybe irritability, maybe happiness, but you could also see other behavioral changes in mood as well, and you could actually see fluid psychosis with a high enough corticosteroid dose or in someone who is sensitive enough. You also see effects long-term when we talk about giving corticosteroids for more than a couple of weeks. We worry about bone changes, ultimately leading to osteoporosis. We see glucocorticoids and corticosteroids associated with decreased bone formation, changes in calcium reabsorption and absorption as well, and bone remodeling leading to loss of bone. And that can be quite dramatic. In a year of prednisone therapy, we could see someone lose their bone density by 20, 30% even. So that's going to be a concern for us. We also see glucocorticoid effects related to an elevation in white blood cells. And this effect, and another thing with systemic corticosteroids is to recognize that at least the cortisol component, the primarily glucocorticoid effect, in normal patients, cortisol secretion is much higher in the morning than it is in the evening. And so if you're trying to mimic that for somebody who works a day work cycle or has a sleep-wake cycle that is typical for most patients, that you would see cortisol levels elevated in the morning and less so in the evening. And so if you're giving a once-a-day systemic corticosteroid, like prednisone, for example, then you're going to dose it typically for that patient in the morning. Aldosterone secretion remains pretty constant throughout the day, but the cortisol secretion mostly in the morning. Where cortisol secretion becomes problematic is for the patient who works the night shift or has a sleep-wake cycle that's different than most of us. And you'll often hear patients who work the night shift, and that may eventually be you as a PA working the night shift. In healthcare, we have a lot of us work night shifts. We find that our body might actually be fighting this cortisol secretion and sort of waging war with that. So important for us, I think, to make sure that we've considered all of the things that affect that. And for some patients, giving cortisol at the time when the patient wakes up is probably the most important consideration. Our choice of systemic corticosteroids, we want to consider whether there's a glucocorticoid or a mineralocorticoid effect that we're seeking. And cortisol itself is 50-50 gluco and mineralocorticoid. Hydrocortisone most closely mimics hydrocortisone. Methylpred and prednisone each have a little bit of mineralocorticoid effect. And so in these cases, we're still going to worry about whether there's going to be fluid effect accumulation with a mineralocorticoid effect and fluid and hypertension, but particularly the patient we're worried about for fluid accumulation would be a heart failure patient or maybe a patient with liver failure and ascites. So we're going to pay a little attention to that. And if we wanted to avoid mineralocorticoid effect entirely, avoid the fluid effect, we could use dexamethasone. And in fact, dexamethasone is routinely used when we want to avoid that fluid accumulation in a case like the use of or the treatment or management of a patient who has met cerebral metastases and cerebral edema. So for cerebral edema, we're typically using dexamethasone because we don't want that extra fluid accumulation to occur. The issue, though, with dexamethasone is if you've got a patient who has been on chronic corticosteroids systemically and has a suppressed cortisol secretion because of that, you have to worry about the risk for no mineralocorticoid supplementation and them actually going through an Addisonian-type crisis because of the lack of mineralocorticoid effect. And in that circumstance, you'd quickly switch them to hydrocortisone. There is also fludrocortisone. Fludrocortisone we don't really use other than in patients who need the mineralocorticoid effect alone. Those might be patients, for example, who have orthostatic hypotension, not responsive to other modalities, where the benefit outweighs the risk. And so that's going to be a concern for us. So all of those are sort of considerations. The administration of glucocorticoids, routes of administration systemically are large, certainly a lot of topical ones we talked about already. But by inhalation, we have inhaled glucocorticoids we use primarily in asthma, to some degree in COPD. There's oral formulations for most of these and parenteral, IM or IV formulations. We've also alluded to our observation that we have a number of adverse effects for glucocorticoids, particularly systemic, where we have a loss of appetite, edema, risk for wound infection, impaired wound healing, calcium and osteoporosis risks there, hypertension, changes in mental status, psychosis particularly, slight risk for peptic ulcers, that risk is low, euphoria maybe, and a loss of glycemic control. All of those are considerations for the use of corticosteroids. We also have some drug interactions with corticosteroids. These are going to be particularly problematic for a patient who's been on a corticosteroid long term. You're going to worry about the patient who's been on long-term prednisone. When you start another drug, that interferes with the effects of corticosteroid metabolism. And so by default, by adding another drug that increases the metabolism of prednisone, for example, you've just decreased their prednisone dose, and that could throw them in a loop or a problem with hypothalamic pituitary axis suppression, that they don't have enough cortisol, and they go into Addisonian-type crisis. So the hypothalamic pituitary axis suppression is going to be a concern when we give more than 5 or usually 10 milligrams of prednisone equivalents a day for more than a couple of weeks. And the presentation of that Addisonian situation can be weakness, fatigue, anorexia, nausea, vomiting, hyponatremia, and hypotension. So our approach here, and we talk more about this in endocrine, is to give supplemental hydrocortisone, typically with mineralo and glucocorticoid effects. So we want to make sure that's aggressively done. And the other risks with the systemic corticosteroids, peptic ulcer disease risk is probably low. Some clinicians look at maybe giving an ACE2 blocker, but even then, the risk itself is low unless someone has had a history of peptic ulcer disease. And in this day and age, as we talk about both in infectious disease and in GI, we often avoid the proton pump inhibitors because of the risk for C. diff, Clostridium difficile risk. We worry about psychiatric effects with high-dose corticosteroids, particularly in patients who have a background of a mental health history. And we can see the grading of the psychiatric effects ranging from just mild euphoria all the way up to fluid psychosis. And when it's significant, we do our best to stop the corticosteroid if that's possible and or institute antipsychotic therapy short term, depending on what we're dealing with. Usually you see the psychiatric effects early in therapy or early after a dose increase. And usually what our intervention is to back off on the corticosteroid if that's consistent with our approach to care and or use an antipsychotic if we have to. Another concern for systemic corticosteroids, particularly high-dose corticosteroids given quickly, is the shift in potassium that is a problem for risk for electrophysiologic changes in the heart and the risk for sudden cardiac death. And so when you're going to give a corticosteroid, methylpred, for example, at a high dose, like a gram of methylpred, if you have the luxury to give it over 2 hours, that's going to be the ideal circumstance for us. And in circumstances where we have that luxury, for example, we're treating exacerbation of multiple sclerosis or some other condition, that's great. Where we give methylpred more rapidly is in a patient who has urgent need, for example, a spinal cord injury, where we want to give high dose of methylpred to prevent the inflammation of the spinal cord to reduce the risk for long-term paralysis. In those circumstances, you probably want to put somebody on EKG monitoring with a rapid administration. But all of these are issues that are not really related to derm. Therapeutic uses, we have lots of them for corticosteroids, and in derm, we certainly see them for a topical application more than systemic. But the systemic corticosteroids, when we use them, usually we dose them once a day orally in the morning. We sometimes give more than once a day dosing in the hospital in an acute situation with methylpred, and then switch them over to once a day, for example, prednisone or prednisolone most often. There are some data for alternate day dosing. I'll refer to those in a couple of slides. Not very commonly used this day and age. That's usually long-term therapy beyond 2 weeks. And most patients these days, we give non-corticosteroids when we're giving anything more than a 10-day regimen of a corticosteroid when we can. Let's now look at some of the infectious disease conditions in dermatology that some of this overlaps with content we've had elsewhere in the curriculum. But let's sort of look at some principles of using or managing infectious disease conditions with topical preparations. So first be said that the topical anti-infectives, whether we're talking about topical triple antibiotic ointment, for example, or any topical solution of an agent, an anti-infective agent, and topically, has a very limited role. Usually what you'll see with a topical anti-infective is that the only thing you can really expect is to reduce the burden or the amount of a bacteria or virus in that particular area of application. And usually it's not curative. So if you have a significant infectious disease process, topical anti-infectives aren't going to get what you need. So that's really said, we're going to limit our topical anti-infectives typically to situations where we want to reduce the burden of bacteria, but don't expect that it's going to be curative in themselves. We're going to need, particularly for anything that's severe or a deeper infection or systemic infection, we absolutely need appropriate systemic antimicrobial therapy. But we can use them for some superficial infections, impetigo with Staph aureus or Staph strep pyogenes, or wound prophylaxis in mild acne. Anti-infectives have a role, and we want to just recognize in serious cases we would use systemic antimicrobials. Let's look first at Bactaban. Bactaban has been around for a long time. It's very effective against Staph aureus. It's really the only topical proven therapy by the FDA for treating topical Staph aureus. And so we're going to use it in circumstances in impetigo or circumstances where you've got sort of a localized risk for staph infection. The other thing that you'll sometimes see Bactaban used as a nasal application is one of a number of options. I see actually more using an alcohol product nasally now for Staph aureus in nasal carriers of Staph aureus to reduce the burden there and reduce potential for transmission. Commonly, you'll see patients reach for or widely advertised neomycin, polymyxin, and bacitracin, also known as triple antibiotic ointment. And neomycin has effects against gram-negative pathogens, polymyxin against gram-negative, and bacitracin against gram-positive. So let's sort of break this down and think about, is that a rationale? Does that rationale make sense? If we're concerned about a dermal cut or wound and we want to give a topical agent to reduce the burden of bacteria around that wound, it doesn't sterilize the wound, but it may reduce the burden of bacteria around that wound, which may help with some degree of wound healing, then we're most concerned about gram-positive pathogens. And the gram-positive pathogens we're most concerned about are staph and strep, for which bacitracin makes sense because that's covering gram-positive pathogens. And so most clinicians just reach for plain old bacitracin cream ointment because that's going to cover what you need. You don't really usually worry about gram-negative skin flora in most circumstances. If you needed gram-negative coverage, then perhaps polymyxin B makes some sense because it covers some gram-negative, but typically that's not even that much of an issue. What we generally, and many dermatologists will avoid is neomycin. Neomycin topically is included in lots of these products because it is gram-negative. It doesn't offer much benefit because we're aiming for gram-positive. The other big issue with neomycin, it's very sensitizing. Almost 10% of the population on average will have a hypersensitivity reaction to neomycin. If it's absorbed systemically, which topical application of neomycin wouldn't be usually, but it can risk for ototoxicity and nephrotoxicity, but usually that isn't a big issue. The big issue is hypersensitivity reactions. And so the bottom line is most clinicians will avoid the triple antibiotic therapy all the time, and if they use it, they will consider just plain bacitracin ointment or bacitracin delivery system to a cut or wound or scrape before you put a bandage on. And even then, if you've done reasonably good wound cleansing, you don't really need this at all. But some clinicians will reach for it. Some patients will historically have used these products. Just recognize that if you're using a neomycin-containing product, you have to worry about hypersensitivity reactions. In cellulitis is pretty commonly observed, and acute spreading of infection that involves the deep dermis or subcutaneous fat. And the non-elevated or poorly defined margins are classically noted in cellulitis. And having sort of clearly defined margins is sort of, you're going to lead to other things we're going to talk about in a minute. But classically with cellulitis, you have warmth, pain, erythema, maybe some edema, tender lymphadenopathy, might be correlated with systemic manifestations of fever, chills as well. And usually there is some recent history of minor trauma or skin abrasion, even a infected skin bite, insect bite, or an ulcer or surgery. We're most concerned about cellulitis in someone who is immunocompromised or in diabetic with poor perfusion when it's seen particularly in a lower limb. So cellulitis can range from lots of different manifestations, and you look at the comorbidities and risk factors as well. But typically with cellulitis, we want to cover for staph pyogenes and staph aureus. Our treatments for cellulitis typically involve either an anti-staphylococcal penicillin, and years ago it was very common to use dicloxacillin, for example, or oxacillin and afcillin. But more often these days, of all the choices we've got, the agent I see clinicians reach for the most, at least those who've had infectious disease input, is plain old first-generation cephalosporin. That's either cefazolin IV or oral cephalexin, Keflex. And for most patients, particularly if MRSA is not involved, or you think MRSA is not involved, and that's most patients with cellulitis, as far as being appropriate for antimicrobial stewardship, a first-generation cephalosporin is our treatment of choice. If MRSA is a concern, and these would be certainly for patients who are at high risk for MRSA, maybe they have had MRSA recently in their history, and or these are patients who have maybe failed outpatient management of cellulitis with cephalosporin, first-generation cephalosporin, you could consider giving them IV vancomycin or linezolid if they're in the hospital, or as an outpatient, P.O.-Clinda, although we often avoid P.O.-Clinda or any Clinda for C. diff, Trimsolv, Bactrim, and that choice often with the hypersensitivity reactions issues. And what I see many clinicians reach for if MRSA is a concern in the outpatient setting is doxycycline, which is generally pretty well tolerated. There are patients who have hypersensitivity reactions. The more issue with doxycycline these days is it's become quite expensive. But the duration of cellulitis treatment is typically a week to 2 weeks, depending on what you've got. In the hospital setting, we might have somebody on IV antibiotics and then continue therapy once they're sort of out of the woods with oral therapy for the remaining 7, 10, up to 14 days. Similar to cellulitis, erysipelas is a concern for spreading skin infection involving the dermis. And this spreads pretty rapidly. Often there will be erythema pain, but here, while it's different than cellulitis, is the edge is elevated and sharply demarcated. And here you're worried about strep infections. You want to get on this quickly. And often IV Pen-G or clindamycin is often our treatment of choice here. In clinical practice, you are likely to see patients with herpes zoster because we now have a very effective vaccine, the newer herpes zoster vaccine released really in the late fall of 2017 has largely replaced the older vaccine, and it's up to 95% effective. We're expecting to see less herpes zoster outbreaks because of this quite effective vaccine, but we still see it. And the goals of a patient who has herpes zoster is to shorten their clinical course, to provide adequate analgesia, to prevent complications, particularly secondary bacterial complications, and to decrease the risk for post-herpetic neuralgias as well. And so our treatment approach in herpes zoster is going to depend in part on the host's immune status, their age, and how they present. So in younger patients where it's relatively mild, we can manage it just with a nonsteroidal if they can tolerate that, wet dressing, maybe calamine lotion, but that's the minority of patients. Many more patients are going to be, by its very nature with herpes zoster, older and patients who have more complicated states. So in those older patients, particularly over the age of 50, more severe cases, particularly if it involves the eye or areas around the face where you're going to look at ocular involvement, where you're going to get an ophthalmologist involved right away as well. In all of these cases, we start with acyclovir or valacyclovir or famciclovir to shorten the course of the disease, and we start that aggressively right away. The antiviral therapy not only shortens the course of the disease, but it's also correlated with less post-herpetic neuralgia as well. So that's, to nipping the viral application early on and aggressively is a mainstay of herpes zoster manifestation in older patients and those where it's severe. We also may require more aggressive analgesic than nonsteroidals. And in older patients, you may have reasons to avoid nonsteroidals anyway. So sometimes these folks need opioids. We also, though, will look at, for neuropathic pain, we'll give them sometimes agents like gabapentin, maybe a low dose of a tricyclic antidepressant if that's not contraindicated and makes sense. We're also going to look in very severe cases whether or not they're candidates for varicella zoster immune globulin. That's going to only be limited to patients who are immunocompromised severely and have a severe presentation, usually going to have an infectious disease service input on that, and that's only going to be a patient hospitalized with herpes zoster. And then you're going to absolutely consider post-treatment, even if they've had herpes zoster already, to make sure they get the vaccine or avail themselves of that. The patients are going to be hospitalized, or anybody with severe symptoms, if they're immunocompromised, if they have more than 2 dermatomes, if they have any facial involvement at all, or if it's more disseminated in its very nature. And so those folks are going to get aggressive management via hospitalized care. Necrotizing fasciitis, very ugly, concerning. It's a type of necrotizing cellulitis involving subcutaneous fat and the superficial fascia, often very painful with gangrene, a serious strep infection. We are very aggressive about this. You get a surgical consult right away for debriding the wound as well as aggressive antibiotics in addition to surgery. And you're looking at ID will typically be involved right away. High-dose penicillin plus clindamycin is typical for the course. And you may add empirically vancomycin or linezolid from MRSA coverage if that's a concern or potential concern, and or piptazo plus metronidazole or ceftriaxone plus metronidazole if there's a concern for anaerobe coverage as well. Diabetic foot infections, often a complication of severe cellulitis in patients. Frequency is a fair amount of diabetic patients will observe this because patients have neuropathies. They often don't feel that. They may have a mechanical injury that's gotten worse. They have reduced blood flow, reduced sweating, dry skin, the vasculopathy, all the immunocompromised state, and a diabetic all lead to this being dramatic. Diabetic foot ulcers are typically polymicrobial, and so our interventions are usually, our antibiotic choices are also pretty aggressive as well. The first thing with anybody who's diabetic and should be appropriate is to look at the preventive strategies. A daily foot exam, appropriate shoe fittings, appropriate podiatry care, no barefoot walking, keeping the feet clean and dry, and to look then at antimicrobial therapy. And you're looking at a first-generation cephalosporin sometimes is adequate if it's a superficial wound and a low-risk patient. But anyone else typically would get much more aggressive. And in the hospital setting, the usual course is anaerobe and aerobe coverage with wide spectrum. Typically, we see piperacillin tazobactam. And often, if MRSA is a concern, and it often is for these patients who are in and out of the hospital, that the concern is to add maybe vancomycin or linezolid as well. And we're also looking at, these are the very patients who might be at risk for osteomyelitis. And so you want to really work up a diabetic foot to confirm there's no osteo in place, because if it's osteo, then you need to manage that with longer-term IV therapy. There is a role for some topical treatment in diabetic foot, Regranex, a therapy that's been around for a couple of decades now. It's sometimes used at a wound clinic. I don't see this used often in the hospital, but a wound clinic may consider using it in addition to maybe hyperbaric care in a limited diabetic foot. And it's fairly expensive therapy. It's in the range of $400 or $500 for a course of week to 2 week therapy. It's indicated for stage 3 and 4 diabetic foot ulcers, usually in combination with surgical debridement and or other antimicrobials, and it's dosed based on the size of the lesion, and you expect an improvement in the first 10 weeks, or it's considered a failure. Some other anti-infective issues you think about are some of the antifungal agents we use, and we can use. So here are some of the lists for the antifungal agents, some of the topical formulations, and keep in mind that when you're giving one of these topical antifungals, you've hopefully ruled out or pretty much identified whether or not it is fungal or not. Maybe you've done a KOH prep or something else to rule that out. And then you want to be careful with when you're using an antifungal and have a fungal infection or yeast infection, you're avoiding corticosteroids to those sites as well. Let's now switch gears and look at some of the more common non-infectious disease dermatologic conditions and how we may manage them. First of all, with acne. Acne, a pretty common condition, particularly if you're dealing with adolescents and young adults. This is probably more common in that population. And the first thing to look at is, are you dealing with acne, or is it something else? And one of the rule outs really is to make sure the patient has not used topical corticosteroid, which could certainly make acne lesions worse. So the first step is stop the topical corticosteroid. Some of our first-line therapies are some simple therapies that are associated with not a lot of toxicity, and one of those include benzoyl peroxide formulations. There are many of them. They're available over the counter. Some are available in cleansers, or lotions, or creams, and they really offer some modest bacteriostatic cytoinfection action against Propionibacterium acne, which is the pathogen associated with acne. And even though it is really maybe an infectious disease process, we usually treat it as one that's not. There are also some topical antibacterials that can be used, topical clindamycin, topical erythromycin as well. And these are really good first-line therapies, maybe before they get to see a dermatologist, as a reasonable, long-standing treatment for mild acne cases. The role of systemic tetracyclines, doxycycline, has sort of bounced around a lot in the last decade or two. There is some data that low-dose doxycycline, for example, offers some benefit and outcomes. But in this day and age where we are concerned about antimicrobial stewardship for drug resistance over time, a lot of clinicians really steer against the role of topical oral or systemic tetracyclines as an earlier therapy, and really reserve it often to the dermatologist role in determining the role of systemic or oral tetracyclines in the management of acne. As we sort of ramp up, our next options in treating acne are the topical retinoids. And tretinoin or Retin-A is a treatment that is topically pretty often used, but it's pretty irritating to the skin. A lot of patients will have topical application, will have significant concern with burning and concern with irritation to the skin and redness to the skin as well. And so some patients really want to start with a low dose of topical Retin-A or tretinoin. The oral Accutane, the isotretinoin, is a category X drug, a drug that is known to be teratogenic. And so we try to avoid Accutane and exposure to Accutane for any woman of childbearing age. If there's an issue where a patient needs to be on Accutane, other modalities have failed, this is really the purview of the dermatologist. Unless you're working directly under a dermatologist, you're probably not going to ever order Accutane. You probably want to get an informed consent. This is an agent that you want to make sure that the woman of childbearing age does not become pregnant, and there is adequate contraception involved or abstinence involved, that the woman would not become pregnant. And so that's a hard thing to do sometimes for patients, and you really want to make sure that you've documented that in the medical record, that you've called them and conferred with them about the risks for risk if they should become pregnant if a patient is on Accutane. Interestingly, the topical tretinoin therapy is not considered real or teratogenic, although I'd still try to limit exposure in a woman who was likely to become pregnant. Some other retinoids that can also be used topically for acne are Deferin is an example of a gel formulation that's used for acne, similar to Retin-A, may be considered by some a step up. We also have retinoids that are used for psoriasis, and they're listed. Some of these are listed here. And so on top of using them for acne, these retinoids are more sort of tailored toward or indicated for more severe psoriasis. And usually these are in the purview of the dermatologist. Keep in mind that we're using these agents, again, they are a risk or potential for teratogenicity, particularly agents that are have a higher risk for systemic absorption. So you want to be careful about that, and the risk for pregnancy and teratogenicity is very real with these, and so I'd be concerned, potentially concerned about that. Other treatments, and we talk more about these agents elsewhere in the curriculum, are the non-biologic treatments for moderate to severe psoriasis, and we may see methotrexate used or cyclosporin used by a dermatologist for more severe psoriasis. We worry about immunosuppression with these agents and maybe hepatotoxicity and the like. They need to be carefully monitored. We need to look at renal function. We talk more about these elsewhere in the curriculum, but important for us to be sort of aware of that. And then the other things that we'll look at for psoriasis, we'll talk about are some of the biologic agents, and we'll get to that in just a little bit. The other things in psoriasis, the anthralin or coal tars, there are vitamin D analogs that are also used in psoriasis. All of these agents, really the purview of the dermatologist, and many of these agents can be a little irritating, and so we're careful about the risk and the benefit of how they're used. Coal tar, a really messy product, and so we see this product less commonly used in this day and age, but used to be the mainstay for psoriasis. But we'll still see coal tar contained in some shampoos, for example, for severe seborrheic dermatitis or dandruff in low doses. It's just staining, it smells like tar, it's messy, it causes increased risk for phototoxicity and sort of certain types of skin eruptions. And so important as clinicians to really recognize that we probably don't use these much, but you want to be aware when you see someone who's using one of these products for dandruff or like. Probably the agents that have revolutionized dermatology in the last decade are the biologics that are used for severe psoriasis or severe psoriasis with a joint pain, psoriatic arthritis, for example. We also use some of these agents in GI and in Crohn's disease or ulcerative colitis. And these are the monoclonal antibodies directed against either tumor necrosis factor or other factors. And they will be quite dramatic at inducing remission in lots of patients, or at least improving symptoms dramatically in severe psoriasis. But these are really going to be the purview of the dermatologist, and most general practitioners are not going to be using these products. An example of one of these agents is Enbrel or Intercept, suppresses inflammation. It's used for both severe psoriasis and rheumatoid arthritis. The big concern with these agents are that they may worsen heart failure. They have injection site reactions associated with them, but we're most concerned about immunosuppression that relates to infectious disease risk. And so we're going to look at whenever anybody's on one of these biologic agents that suppresses immune function, we're going to always rule out in advance? Have they ruled out for TB? Have they ruled out for other viral and systemic infections? They don't have a current infection going on, and we're going to avoid live vaccines with them while they're on these agents as well. Any of these related drugs are the biologics that suppress immunity. We're going to worry about that. We're most concerned about serious infections and or maybe long-term risk for lymphomas or other types of cancers when patients are on these anti-TNF drugs. And so because of that, there's a real risk associated with these agents, but the benefits often outweigh these risks in that the psoriasis, if it's severe, has been so dramatic that patients are really seeking an alternative. And so there are a number of agents. Some of these are now available orally as well as every 4, 6, 8-week therapy modalities intravenously, but all of these really under the purview of the dermatologist. If you see anyone on any of these disease-modifying drugs, though, even though it's ordered by the dermatologist, you as a clinician need to recognize that, particularly if you're working them up for an acute infectious disease process. They come in with pneumonia, cellulitis, gastroenteritis, who knows what. You need to recognize that these drugs, by their very nature, is going to render this patient immunocompromised, and so you need to then deal with their infectious disease state as though they're immunocompromised and manage their therapy for their infectious disease state a little more aggressively than you might otherwise. Okay, let's now look at some of the newer treatments that are alternatives to corticosteroids, particularly in the management of atopic dermatitis. Historically, and we still use for atopic dermatitis, corticosteroids pretty commonly. Corticosteroids are cheap. They work pretty well. If we have a fairly limited site of application, we don't really worry about suppression of hypothalamic pituitary axis. But there's a few new products on the market. And one that's sort of getting a lot of direct-to-consumer advertising is Eucrisa, which is a phosphodiesterase 4 inhibitor, which increases intracellular CMP levels. It's a non-corticosteroid. It's applied twice daily. It's pretty well tolerated. The problem is it's very expensive. And so without insurance, a $600 expenditure for a patient is going to be a problem. And even if patients have insurance, they may require a prior authorization before you can order it, or if it's allowed, their copay still may be quite high. And so really cost is going to be the rate limiting step for this agent. Another older alternative that is really not used much anymore is Elidel. And this had been around about a decade or so ago, but all of a sudden, certainly after it had been on the market for a short period of time, there were reports associated with problems associated with immunosuppression that were significant enough to pose risks for, among other things, lymphomas. And so Elidel is an agent I've not seen used. Now, granted, I work in acute care, so I wouldn't likely see it anyway, but it's an expensive agent that has posed some safety concerns that render this product really rarely used. Another situation for atopic dermatitis that is more severe is a monoclonal receptor antagonist for interleukin-4, approved in 2017 for severe atopic dermatitis not controlled by other topical modalities. Very expensive here modality. It's going to be limited to folks who have not responded well. And we're talking about, in the range of $3,000 for a course of therapy. And so important, really, in patients who are quite severe and who have not responded to other modalities. Other things that we think about are topical antiviral agents, and again, whether this is infectious disease or not, kind of is. But we're thinking about topical herpes simplex infection, a cold sore infection, where there are topical antiviral therapies. And we have a number of these agents, topical acyclovir, topical pencyclovir. These may reduce the burden or the the severity and maybe shorten the duration of the cold sore if it is started immediately at the outbreak of the cold sore. How these work is as antivirals, they prevent viral replication, but once viral replication has happened, you're just reducing the extent of it. And so typically what you'll expect to see is maybe shortening by a day or two and decreasing the severity if we start these topical therapies immediately at the outbreak of the cold sore. For perianal or genital warts, there are a number of antiviral therapies that can be used. These can also be used for severe plantar warts as well. And Aldura is a moderately expensive agent that is pretty irritating but works pretty well. These might be patients, for example, you might see this used in a diabetic with a plantar wart for whom you don't want to do too much surgical intervention for the risk of infectious processes. I sort of say this anecdotally, but there was data a couple of decades ago for duct tape applied to a wart that actually offered some benefit and in fact seemed to work better than even cryotherapy or freezing techniques did. And the data here is whether or not it's occlusive nature, or whether it was something in the adhesive of the duct tape. It's anecdotal. It's not a great defined study, but you may hear patients talk about this. And I've heard clinicians over the years more or less don't see this as a modality people use anymore, but you may hear people talk about this. Some things to think about for patients who have a skin eruption is to first ask the question, is this skin eruption related to the drug they're on? And so I'd encourage you to look at a Medscape site that link is listed here. You have to get into Medscape, assign into Medscape, but they have a nice little series of slides that look at some of the common skin manifestations, fixed rub eruptions, maculopapular rashes, urticaria, what it looks like, what the time course or what the presentation is like, what kind of causes it. And when we have to have a fixed drug eruption or a rash that's related to a drug, the first issue is to stop the affecting drug. We could consider antihistamine therapy, usually Benadryl or diphenhydramine, topical corticosteroids, maybe a pulse therapy with prednisone as well, and expect a clearing within a couple of weeks' time. One other issue to think about are drug-induced phototoxic or photosensitive reactions, and these occur when a patient has exposure to a drug, gets some sun exposure or tanning bed exposure, and then presents with a reaction. And these type of reactions, dermal reactions, are often dose dependent, depending on the agent and the exposure of the sunlight. They can present as an exaggerated sunburn. They can actually cause vesicles and bullae as well as certainly redness and hyperpigmentation. That's pretty common. So what we'll see in photoallergic reactions, immune-mediated reactions, we'll see versus phototoxic reactions is often related to the time course, and we'll sort of see this presentation in differentiating this presentation in the next slide. So with photoallergic reactions, you have the drug that plus the IV light, and then the drug is altered chemically. Half-ton of the drug, a portion of the drug, is joined in the skin protein to form an antigen, and then on re-exposure to sunlight days later, you get the reaction happening then. Whereas a phototoxic reaction happens pretty quickly, the drug plus the UV light photoexcites the drug, and then you have a skin reaction in the dermis itself that releases energy and causes that burning. The type of drugs associated with photosensitive reactions are listed here. In clinical practice, some of the antibiotics include the tetracyclines that we worry about for phototoxic reactions. We'll also see other antibiotics sometimes be problematic, but the tetracyclines and the quinolones are the agents, sulfonamides are the agents we'll see the most often for particularly phototoxic reactions. And then sometimes you'll see other drugs causing a risk for phototoxicity or photoallergic reactions as well, particularly the phenothiazines we use in psychiatry. Finally, to wrap up the dermal therapeutic block, let's look at some management of ectoparasites. And particularly, we worry about the concern for lice and scabies. Let's start with scabies, which is often more dramatic in presentation and quite often can be quite contagious depending on the type of scabies. Is caused by an itch mite of one type or another. There are different types of these. And transmission can be by towels, it can be by linens or clothes. That becomes problematic. And they also can be present with very intense itching at the site of infection or infestation, particularly at bedtime. And then you have to worry about secondary bacterial infection as well. You have to treat the entire surface except the face or the scalp in adults, and then aggressively manage the bed linen and the clothing. And there are a number of different topical treatments, and oral ivermectin is a possibility as well. So we'll go through some of these therapies in a bit, but permethrin is in most cases a drug of choice. And if it is, depending on the type of situation it is, and the type of scabies, if it's isolated, may be more contagious and may be resistant to some of these modalities. Infestation with lice, typically the most common two manifestations are going to be either pubic lice or crab lice, which is often sexually transmitted by sexual contacts, and is usually limited to the dermis but can be on men with facial hair there. Can also be seen in eyelashes as well. And treatments of choice here are permethrin typically, or maybe malathion. And we use often either sterile ophthalmic petrolatum or sometimes erythromycin ophthalmic ointment, not for the erythromycin component, but just for the component of it's a cheaper formulation of ophthalmologic petrolatum that could be used. And then we want to wash any bed linens in very hot water and dry at a very high temperature. Head lice and body lice are also commonly seen, head lice particularly, and these are most often seen in school children or daycare centers where they become endemic. And what the issue is here is to manage the nits as well as the lice themselves. And so the application typically is you give an application of permethrin product is usually what's given, and you apply it for 10-minute time as a shampoo. The application is typically started at the back of the neck and then working up behind the ears, moving frontward, applying it for 10 minutes, soaping it in well, and then rinsing it very well and using a nit comb to try to remove the nits. May require a second application after a week or so. And managing it by cleaning linens and hats and all those kind of issues, as well as treating close contacts, dealing with hand brushes, furniture, and other objects, particularly as it's associated with the risk for head lice. Body lice is less common, except in areas where there might be infestations, particularly might be seen in homeless shelters or other areas that can be observed. And issues here are removing all the clothing and then treating with an appropriate agent, usually permethrin or malathion, disinfect the clothing, disinfect all of the linens involved, and go from there. Most of the interventions for ectoparasitic infections are in the forms of creams, gels, or lotions or shampoos. Topically, only ivermectin is the only choice orally, and that's really a second-line therapy in all indications, not first-line. So first, let's look at permethrin, which is available over the counter, and this is a first-line choice for almost everyone. And our treatments are mites, lice, and ova. It kills adults. It also is effective against fleas and ticks. And there are other formulations. There's a 5% formulation as a cream for scabies, typically effective as a one application only, although I will tell you there's a lot of stigma associated with scabies and lice and head lice and body lice and pubic lice. And so patients have a sort of this phobia, and if they have an irritation or itch associated with it, their concern is going to be that they're going to fear that even though the first treatment may be effective, the residual itch makes them think they need retreatment and it hasn't been effective. So you want to be aware of that. But if you're dealing with lice where there is, for example, a nit, and you haven't cleared the nit, which are the eggs, then you have to worry about a second manifestation within 5 to 7 days by not effectively moving those nits with a nit comb and a process to remove that. And most kits that are available over the counter for patients available in a drugstore have all of those, everything that they need to be able to manage both the lice and the nits themselves as well. Permethrin is pretty well tolerated, not a lot of serious effects, maybe some itching or exacerbation of itching, but usually that's the residual effects of the lice, not so much the agent itself. And you have to really follow the directions scrupulously for these agents. For head lice, a 10-minute application and retreating in 7 days, if you need to, but most folks don't need retreatment, works well for head lice. For scabies, on the other hand, you want a long-term application of a higher percentage, and this is massaged into the skin. Patients then sleep, usually overnight, with it, and then wash next thing in the morning, and that's typically what's done for treating scabies. Malethion's an old organophosphate therapy that is toxic with exposure to animals, but in humans it's metabolized to a non-toxic metabolite, but it's not really first line. It's really considered after permethrin is not effective. It's available as a 5% lotion that works pretty well, so it's an alternative to permethrin products. Urax also is an option that's used sometimes in scabies. I think more effective in Norwegian scabies, for example, a more contagious form of scabies. And you can get a mild dermatitis with it, but more often it's really the scabies itself that has caused the dermatitis. It's available as a cream or a lotion, and again, it is kept in, applied to the appropriate areas, and repeated in 24 hours. There are also combination products that are available, permethrins plus piperonyl butoxide for pubic lice and head lice, and this is a combination that might work better than permethrin products alone. There is a benzyl alcohol 5% product that suffocates lice. This is also a treatment option, but it's more expensive. An even more expensive product, Nitroba, is one. I haven't had any experience with this product. It's a pregnancy category B agent, safe in pregnancy, but limited to patients over the age of 4 years, and again, fairly expensive modality when the cheaper therapies are $10 to $20. An older product that is occasionally still used is Lindane or Quell. It's pretty effective, but our concern is that it's quite irritating and can cause seizures and be systemically absorbed, particularly in younger patients or older patients. Infants and children, we usually avoid this drug because of systemic absorption, and older patients, we may want to avoid it as well. But it can be effective if you follow the appropriate treatment options and directions for Lindane, but again, not used very much. Ivermectin is available now both as a topical preparation, also pretty expensive, and as a single oral dose. And ivermectin has been available for years for treating worms as well. It's also used in veterinary medicine as the drug of choice, typically for treating heartworm, preventing heartworm in dogs, for example. But in humans, there's human data for it as well, and it works to cause death to lice and their eggs. Oral treatments, other treatments that are available for lice include, there's one study that was done, a small study done years back for Bactrim or trimethoprim sulfamethoxazole for lice. I've not had any experience seeing clinicians do that, but as a last or a late resort, that might be an option for something that doesn't work otherwise. Or topical preparations that often occlusive nature that suffocate them. These are probably less effective than some of the other therapies we've got. Cetaphil cleanser, petroleum jelly or Vaseline, mayonnaise, olive oil, occlusive by their nature. But most clinicians don't look at these as first-line therapies. So in dermatology, I think it's important to recognize some of the drugs you'd expect to know typical doses, Benadryl, for example, diphenhydramine, and maybe prednisone, pulse dose prednisone.